Okay, hi, this is Lynn Chell. I want to welcome everybody to the first online Journal of Addictions Nursing Journal Club. This is pretty exciting. I'm sorry we're just a little late starting because we're negotiating some technical issues, but I think we have it all set up. I'm wondering if we just wait a few more minutes, 2 more minutes till 12:05, because I know I had to do some setup work first. So I just would like to give everybody an opportunity to get in, and we'll start at 12:05. So if you're like me, you've already gotten your glass of water. You all have been unmuted. So Dennis, do you want to just try to say hi so I know that end is working?
I can hear you. This is Beth Glicker.
I see that. Thank you. I think we caught Dennis snoozing.
No, actually, it said it was muted, and I got it unmuted. Can you hear me now?
I do. I do. Okay. Oh, Christine is there too. And Vera, I just want to make sure that everybody has figured this out.
One thing, Lynn, it's 9 o'clock in California, so I'm having coffee.
This sounds pretty good. Vera, can you hear us?
It's 12 noon in Pittsburgh, and I'm having coffee too. This is Ann.
Good. Okay, it is now officially 12:05, so I think we'll go ahead and get started now that I know that people are able to connect. I am so happy to be here. We've had this journal club during the annual conferences. This is our first online time. We're really fortunate today because we have the author of the article we're going to be discussing online with us. So before I introduce him, I just want to invite everybody to share opinions, experiences, any questions during this hour that we have. I think that as I've explained to Dr. McRae, in the past, the people who've attended the meetings have given really great feedback to the author and vice versa. It's a bi-directional beneficial relationship. So hopefully we'll have a good dialogue. The article that we're discussing today is Assessment Protocol for the Older Adults with Substance Use. Hopefully you've all had a chance to read the article. It was first appeared in the Journal of Addictions Nursing in the most recent issue, October, December. And I know you all had access to it. Just a reminder, you can also get CE credit, and I'll talk about that at the end as well. So it might be something you're interested in if you've already come to this and you've read the article. So let me first start by introducing the author. Dr. Kenneth McRae comes to us. He is a graduate, a Doctor of Nursing Practice, a DNP from the College of St. Scholastica out in Minnesota, where it's really cold, and Dr. McRae should be having a cup of coffee or hot chocolate, I bet. He is a board-certified adult gerontological primary care nurse practitioner, and he is adjunct faculty at both the University of North Dakota and the Minnesota State University. So he is a busy fellow, so I really appreciate that he's taken the time to join us. I guess I want to start by saying that Dr. McRae, your article really talked about a quality improvement project that was focused on geriatric syndrome. I'm always discouraged when I hear that the geriatric population is now referred to for people who are 55 years and older. but your population was 55 years and older and admitted to Minnesota Substance Abuse Treatment Center. And I'm wondering if you could set the stage for us and share some information about your treatment center and your role in it, and then specifically about the unit that was in your study.
Sure. Okay. Hello, everybody. Good morning or afternoon, depending on where you're located. It is a balmy 19 degrees here in Minneapolis today, which is actually really warm for us for being January. So actually, we're all thrilled about it. So thank you all for joining me today, and thank you for the invitation to be here. So there's this quality improvement project. You know, when I needed to find a topic for my D&P initiative, and at the time I was working at this treatment center. It's a large place here in Minnesota, and I knew that I wanted to do something with the older adult population, but I wasn't quite sure what direction I wanted to go. And so at the time I was working as the only nurse practitioner at that treatment center. And so I worked in conjunction with a couple of physicians. And the topic actually came up accidentally because during one of the days where I was on call, one of the nurses had called me and she said a patient was having trouble ambulating. So they were having difficulty walking. And so my question to her was, is this a new problem? Has she been like this? What can you tell me about it? Well, the nurse was unsure, and actually the patient had been there a while. And so it triggered something in me thinking, okay, so this patient has been here a while. She's an older adult. She's been in withdrawal from substances. And now we're just determining that she's got a problem with mobility. And so it got me thinking, okay, what are we doing? What are we missing here? And so I looked into what was our practice at the time for identifying some of these things. And honestly, there was no process. There was no assessment. And so there was a lot of questions about what kind of substance are you using, or how long, or have you been to a treatment program before? But there was no questions such as, do you have any trouble walking? Do you have any trouble sleeping? Do you have any trouble eating? Those type of things. So it really got the ball moving forward. And that's how I got to that topic, just from that single occurrence. And then it turned out there was more and more things that happened. And what really happened is this baby boomer population appeared, and they were at the treatment center very unprepared for the sudden increase in admissions of the 55 and older group, because it wasn't something we had seen in the past. We were seeing the 18s, the 25s, the 35s, but the 65s and even into the 70s and some of the 80s we were not seeing. So all of a sudden there was all these shifts in population.
Sorry, it took me a little bit of time to unmute myself. That's really an interesting point, because I predominantly work in outpatient, and I would say that my population is still predominantly 18 to 40s. I don't know that I've had too many baby boomers. They're still a significant minority. I'm wondering what the rest of you are seeing.
This is Dennis, and I work outpatient mostly also. We have a residential program associated. However, we do have a lot of elderly veterans. Is where I work, and they definitely have multiple issues relating to sleep primarily. Mobility is part of it.
Is that you typing, Dennis? Were you going to say something?
No. Did you not hear me?
I did. I wasn't sure if you were continuing.
Oh, okay. Well, I was kind of giving other people a chance to chime in.
Got it. I know. Thanks. It looks like Todd, did you have something to add?
Hi, yeah, this is Todd. Can you hear me okay?
Yes.
Sure can.
Yes.
Great. So we work here, we're an inpatient unit, and we do both withdrawal management and rehabilitation for drug and alcohol here. And we see a majority of older patients, baby boomers, a lot 50 to, 70 years old generally, and they're very deconditioned. So adding some type of assessment for our older adult population to try to avoid some of our adverse events, such as we see a lot of falls, patients, and pain management for these patients, here on this unit is quite complicated too, since we don't have too many things to offer them to manage their pain while they're here in the hospital.
Todd, where do you practice and what is your role there?
So I'm a nurse clinician, so kind of middle management here of our unit. I report directly to our unit director, and I'm at UPMC McKeesport in Pittsburgh, Pennsylvania.
Oh, wow. Okay.
Mm-hmm.
So it sounds like you are pretty much having the same experience that Dr. McRae was having.
Yes, yeah, absolutely. And we don't do anything different currently as far as assessments with patients, based on their age. But it is, absolutely something that leadership here is kind of interested in looking at and exploring further, just as a unit to ensure, quality care for our patients. If we could perhaps add an assessment or, to determine what other how we're not meeting their care, and how we can avoid some of these adverse events that we've had.
Well, both you and Dr. McRae probably understand the term geriatric syndromes better than I. I haven't worked in geriatrics for a while, but Dr. McRae, you cited a significant number of, like 50% of hospitalized older adults were experiencing geriatric syndromes before they even got to you. So I'm wondering, could you just explain for those of us who are not geriatricians or have a predominantly geriatric practice, what the term geriatric syndrome means?
Oh, I don't know if I can do that.
I'm sorry, I shouldn't have.
Yeah, no, that's okay. Since I'm primarily just an addictions registered nurse.
Addiction.
Yeah. So we don't necessarily specialize in the geriatric population. It's almost just seen something, since we are inpatient hospital, the patients who do qualify to be here for a rehabilitation stay tend to be of that age group. But just in general, kind of what we've experienced, I think within the realm of these syndromes, certainly it's a lot of deconditioning that they're coming in. They're just not really strong enough to kind of handle the demands that drug and alcohol rehab put on them, as far as being able to independently get to group and walk. So we have a lot of physical therapy consults here. But even with that, the patients aren't quite strong enough to really be able to participate as much as we would like them to, in the group therapy process.
Todd, I bet you have something to add to this, and I just want to say to everybody, you don't need to raise your hand, even though you all are so well versed, about doing that. Just please add your comments as needed, as you want.
I can chime in again just to clarify the geriatric syndrome. Yeah. So the most prevalent geriatric syndromes are things like functional decline, that's a big one, falls, skin breakdown, sleep, alterations in nutrition, incontinence. So those are the big ones, and those were the ones that are captured with the Spices tool that I used for this particular project. And the results did show that the sleep was quite 32%, or it was a large number of people in there. Within this research group or within this sample, 32% of those people did have sleep issues, not to mention other geriatric syndromes, but in general, those are the more common geriatric syndromes. Functional decline is I would say, one of the more common ones.
Well, this is Dennis here, and I find a lot of people, especially post-alcohol, do have sleep disturbances, whether they're younger or older. I think the younger folks complain more about it. The older folks are probably more used to it, especially a lot of my population, being veterans, has been subject to PTSD, depression, anxiety issues, along with the substance use, dual diagnosed.
Yeah. I think you make that point, Dr. McRae, that it's a bi-directional relationship between sleep and substance use.
And yes, that's true. The literature does show that, and those of us that work with these types of patients, many will tell you that they use alcohol or other substances because they can't sleep, and then in turn, these substances cause insomnia in some cases, or a sleep disturbance, especially during that acute or even post-acute withdrawal period. So alcohol, you will hear it. Some of these older folks will say, "I have, a shot of brandy because it helps me sleep." Well, of course, there's sometimes more to the story, but then later on, their sleep disturbance is exacerbated. It's already, significant. It's worsened during this withdrawal period. So yeah, there is that bi-directional relationship between a sleep disturbance and substance use. That's absolutely true.
I'm also kind of curious. I don't know if Todd is still on the line, but I had not heard of the spices tool. I
had not either.
I was going to ask how. This is Chris. I'm sorry to interrupt, but it's in conjunction with your question, Lynn. How you came about choosing the spices tool? If you could elaborate on that, thank you.
Yes, absolutely. So it was an exhaustive literature search because I really had no idea how I was going to assess these types of things. There's a lot of tools out there that will measure an ability to ambulate or ability to get up and go test. There's these a lot of different tests, independent tests that you can use. But in order to find a tool that was easy to use, that captured as many of those key things as possible, and something that was not going to add a work burden to an already busy place. So when I saw the spices tool, it just seemed like the best thing because it really did, and the literature supported its use across many settings. And so when I looked at that, it looked like it was going to be the nurse to into the current workflow, simply check a box versus adding a lot of time, because it's very difficult when you have a lot of admissions and patient flow and that kind of thing to have a new process and something that's going to be time consuming. So the nurses, there was a very high buy-in rate to this because it was easy to use, and so they were actually willing to do it readily. So I came across it through a literature review, and that's how I found it.
It is a really simple form, Chris. Were you able to see it?
Yeah, sorry, I had to unmute myself.
Yeah.
Yes, Lynn, I liked it, and I understand that there's some validity and reliability that you found with the tool as well, and I'm assuming it's with the specific to that population in terms of well, I guess not necessarily geographically, but ethnically and culturally. But I was curious on another context, perhaps some of these issues with sleep disorders that have been or sleep issues that are bidirectional, that are probably long-standing with many of the patients. I'm real interested in sleep and substance abuse and how that might, have generated at least the onset of the substance abuse disorder. That I'm wondering if some of that is rooted in anxiety or early administration of alcohol to some of these patients when they were infants or young children to keep them quiet, and so they kind of had sleep problems maybe from a very early age. That's just something I'm just throwing in there.
Mm-hmm.
That I think is true. They will tell you they have not slept well for decades. But then I also heard that just some of the loss they experience as they've gotten older into their 60s, into their 70s, and even the 80s that I saw, the loneliness triggered an increase in alcohol. So
well, I bet that makes sense.
Yes, so whatever they had before, they may have had their sleep remedy may have been a little bit of brandy at bedtime, but then when the husband died or the wife died, suddenly the brandy crept its way into the afternoon, crept its way into the morning, that kind of thing. So it just seemed that over time, depending on the other life circumstances, maybe something that wasn't a big of a problem before became a real big problem.
Right.
Hello.
Yeah,
Dr.
wow.
Can you hear me?
Yes, Vera.
Yes, I have a question for Dr. McRae.
Yes.
Why do you suppose nurses are not optimally trained to assess the older population? I would like to hear your thoughts on that.
That was also a little bit surprising to me because the majority of my career has been with older adults right from the beginning. So my assumption was everybody knows how to take care of everybody. So when we started to see this increase in these older adults, the nurses just were uncomfortable. And I'm not sure it's because I think it's because of probably their experience and where they had worked before. They just didn't have that exposure. I do know that the education system now, depending on schools, depending on requirements, geriatric and older adult content has gotten either squeezed in or squeezed out or minimized, or it's become a little more of an option. Whereas when I was trained a while back, it was a requirement. We did rotations with older adults, and we had to learn older adult content. I think that that's happening maybe more now because just of the population shift in nursing programs have determined that, hey, we just need to really address this need. But the majority of the nurses that I worked with at that time during this project were very uncomfortable with older adults because they didn't recognize that maybe there might be normal variations in lab reports, for example, that is expected with an aging person versus a 20-year-old. It was like the thinking of maybe a one size fits all, everybody kind of has the same thing. So when it came to assessment, they didn't really think that, okay, maybe there's some special needs here that we really need to look at, like mobility or problems with ill-fitting dentures, for example, questions that were never asked, but then when this project came out, it really triggered them to assess or look at the patient differently and not so one-dimensionally.
Thank you.
Yes.
Dr. McRae, I'm kind of curious. I don't have a feeling for the group of nurses that you have work there. So in my head, I've kind of been imagining that they're perhaps an older group of nurses who have been working perhaps in an addiction setting for so long that they see themselves mostly as addiction nurses. And now, as you brought up in the very beginning, as the numbers are increasing, it just hasn't been part on their radar to do evaluations for a geriatric population. Do you think that's possible?
Exactly. So the nurses at the time of this project, we had about 50, I think 53 that were included. And there was a mix of them. There was newer grads, both LPNs and RNs, different levels of training. We have, I would say that we have a pretty good education system here in Minnesota for nursing. But at the same time, the older nurses that had worked a long time, that really had a lot of other life experience, maybe other exposure in their initial training, were more comfortable. But it was almost like the middle group, the 30 to 40-year-olds had maybe worked more with psychiatric patients or just the substance abuse and hadn't seen these older group. So there was several different levels of experience, but in general, there was a lot of pre-surveys that I did on this to try to establish, okay, what is their knowledge level? And I gave some questions for them to answer. What was their comfort level dealing with this? And gave different scenarios. And most of them were uncomfortable with the scenarios because they had just a lack of exposure to begin with, or it had been an extended amount of time since they had either thought about it or actually done it.
And that was the main aim of your project, if I'm remembering correctly, right? The specific aim, the primary aim was to increase the nursing knowledge.
Exactly. There was two aims. It was to increase the nursing knowledge and then to identify those potential geriatric syndromes.
This is Dennis here. I'm interested in the table that you have in the article referring to transfer to a higher level of care. The pre-intervention had 14.8%, and the post or the intervention reduced to 12.3%. Can you speak to that a little bit?
The transfer to a higher level of care, so that typically meant that they were sent out in an ambulance to a hospital setting. And so we did notice a slight, well, actually it was a pretty big decrease, 5 less, so there was a 12% drop. And I'm not exactly sure of what we can attribute that exactly to, other than we had less falls. We were able to identify some of those changes in cognition. We were able to, when we had a better baseline idea of what they were like, we were better able to assess if they were worse. So instead of something all of a sudden really being a nurse thinking that it's an emergent situation, perhaps that was the situation all along. So it was just this assessment added a layer to the initial process. So we had a better baseline. So I think the decrease in the transfers to a higher level of care was a result of better assessment and just the nurses being more in tune with the patients.
Yeah, I appreciate that, and it also, shows more of a pre-intervention that tries to get people to become more aware of these potential problems, and it's also a dollar thing, specifically for the patients.
Exactly. Yep, exactly. The early assessment equals early intervention, and that's true for all settings, really. But in this case, when you already know that it's going to be really a difficult road for the patient, if establishing the need for providing something as simple as a walker for them to stabilize while they're trying to get through their alcohol withdrawal saved us on falls. It saved us on some of those one-to-one attendance that we were using because somebody had an unstable gait. So some of those earlier things really did help.
That's wonderful.
Hi, this is Vera again. I have another question. So In your article, you stated that 53 nurses in total were employed by the organization. However, only 38 attended the educational program. What did you find were some of the barriers to non-attendance?
Something that was not included in this article just simply because of space, and it wasn't all that relevant to this. There were several of those nurses that had gone out on either vacation during the time of the education, or I know there was one or two that were out on a maternity leave. And then there was a handful that just didn't attend. Now it was a mandated education session by the leadership there at that facility. So there was still some that did not attend, but I had initially gotten leadership to say, no, we need these nurses to be educated on these patients. So yeah, the majority was just because of overall absence or leave of absence or vacation. But those that were around were more than willing to attend, and it was an hour-long session that we had.
And can you, what was the educational format? Was it lecture?
It was a lecture. It was a PowerPoint lecture. I offered it multiple different times on different days. And it was essentially a PowerPoint, and we talked about the specific characteristics of the older adult nurse substance use. So why are they prone to substance use? And we talked about losses. We talked about loss of independence. We talked about imposing substances on top of chronic medical problems and what that can look like. We talked about normal aging processes, and we talked about how labs can vary. And then I incorporated this new process. So we talked about not only a little down and dirty of the older adult, but we talked about how we were going to assess them using this SPICES tool and what to look for, and laid the project out essentially. So everybody got the same information.
And then one more thing. So in your article, you said that non-nursing staff also attended. Who were they, and were they factored into the QI project numbers?
They were not included in that 53. There were nursing assistants that attended. There were some of the there's several medical assistants, that people responsible for drawing blood or doing some of the clerical work. They attended. And then there were the medical staff attended. And so although the physicians were not required to do this, they were very supportive of the project, and of course wanted to hear what I had to say about the older adults.
Oh, great. Okay. Thank you.
You're welcome.
So the numbers in your article reflect all people who attended the session, the intervention, or who took the pre-test?
Yeah, the pre-test, post-test.
Yes. And so you're saying that 53 of those were nurses?
Of those 53, the total number of staff employed during the project was 53. And then of those 53, 38 attended the program.
Okay. Thank you.
And Dr. I just wanted to add, Karen Regasis is having a difficult time logging in, but she sent a message that I'm going to relay to you all, which says that she sees patients who are over 55 with substance use disorder issues. And also to let us know that you can find the SPICES tool on the Hartford Center for Geriatric Nursing. The Hartford Center has wonderful resources for geriatricians and geriatric nurse practitioners. And then she adds that she's a psych NP and a weekend attending on an inpatient psych unit. Thank you for adding that, Karen.
Thank you, Karen.
A lot of interest in the SPICES tool. I'm glad that we're here to ask questions of you.
Yes, I've had to explain to many people that come across it and they've never heard of it. And and I'm talking about people, psychiatrists have not heard about it, other people that care for geriatrics. because it's not something that you would typically, or that we've used in practice. I think we use other methods now, but I think it's it at least opens your eyes, and you're forced to think about, okay, what about their mobility? What about this? What about that? Because it's not always something that you might capture in a routine visit. If you were even if you were going to see them in a primary care setting, it's certainly something that could be used then, and it could even be done by the nurse then. So it's a very easy to use tool, and even if it needed to progress on to more of a comprehensive geriatric assessment, I think it's a very good, quick, reliable way to start.
Well, the fact that you identified, I think, was more than twice the admission abnormal findings when you compared the pre and the post numbers really indicates its usefulness as well.
Yeah, just having some frame of reference for changing the way the nurse thinks or was thinking at the time. And so after a while, I would say even after the project ended, the nurses had shifted their thinking. So it was becoming a little more automatic. So we were able to cut off some of those sleep issues right at the beginning, and it didn't go on and on. And same with like I already gave the example of providing a walker. We had more walkers in the facility. We were able to really get the nutrition services on board and say, okay, this patient probably needs a little more of a mechanically altered diet because they're ill-fitting dentures. Some of those simple interventions really made a huge difference at the beginning. And I think these patients were able to get through their initial acute recovery period a little bit quicker when some of those things made them more comfortable.
Right. One of the things that I thought was interesting when I looked at your chart that in the article, while it seems like you pointed out a decrease in the transfer to a higher level of care, so I'm interested in that just as Genesis, but then you also found an increase in the adverse outcomes, including problems with sleep, and I think something else that struck me, and I can't remember right now, but it seems kind of opposite what you would expect.
The sleep one was the most prominent here with what we found, and the reason it became more prominent is because we were actually asking the question. So before, when it was pre-intervention, it was not part of the routine process to ask them about sleep. And we even found that when we were doing the initial provider history and physical, it may or may not even be asked. We may ask it, how's your mood today? But it was not part of our normal workflow. And because it's busy, and so it became, once we started actually asking a question, we were able to identify it. But prior to that, when we didn't ask the question, quite often the patient did not volunteer the information.
Interesting. Karen has a follow-up question. She wants to know if the administrators support including the SPICES tool in daily care.
I missed that last part of the question.
Yeah. Her question is, have the administrators supported including this, which I believe is the SPICES tool, in the daily care, or perhaps just an assessment tool for the daily care on a daily basis?
After I completed this project and had all the results, I did a wrap-up presentation with the leadership there at the facility, and I had offered some next step suggestions and some indications for future practice. One of them was to incorporate this tool or a similar tool into the admission process, and the other one was to actually use a formal sleep assessment tool. And the inclusion of those kind of things into the workflow at that particular facility required a lot of approvals, a lot of discussion in that. And I will say that just over time, I had left the facility after that, and there was I'm not sure. I think if I would have stayed on longer and really taken it to the next level, I think I could have done another study on actual sleep and identified these sleep patterns, or identified really cut on maybe a little deeper about the sleep issue. They were in support of it, but yet at the time it was not, nothing was implemented.
I would think that they would be interested, given that there's a decrease in the transfers to a higher level of care. I would think that that would be a huge variable that they'd want to at least look at a little bit more.
I agree, and I really encourage that. The challenge at one point was the tool itself, or the tool I had used was a hard copy, and we were using a computer, electronic medical record. So my suggestion was, well, let's then look to what is available for the vendor for the electronic medical record. Let's see what the vendor has that's similar to this. If we can't use this, because I think the Spices tool, there's probably going to be copyright. So it would be some legal things that you'd have to go through if you were going to use it for an ongoing practice like that. I'm not exactly sure, but I did really push that, whether it be a Spices or whether it be some other evidence-based tool, to get this going. And although it sounded promising at the time, I'm not sure that it's happened as of yet, despite the financial and patient outcomes that would really be of benefit from some of these early interventions and whatnot. I'm not sure that practice has changed.
It's always hard to change process, isn't it?
When you
I'm wondering. Yeah, I'm sorry. Go ahead.
It's always been this way kind of thinking that can be a little tricky to deal with.
Yeah.
I'm wondering if anyone else on the call is in their settings, if they do any ongoing assessment of sleep. And we're doing a special issue in the future on sleep and substance abuse. Dr. McRae, if you're interested in, I know you said, I think you've changed your practice now, but perhaps you might have some additional data that you might want to contribute to that. I don't know.
Yeah, although I've changed practices, I still work with the substance abuse population in a slightly different role, but I definitely think that it's still relevant. And I probably can look into see what my numbers show, but I certainly think there could be an evidence-based paper that could contribute to that issue for sure.
Great.
Karen Regan, good question. Wondering how much of it is really a financial issue. Was there any cost incurred by including the Spices in the evaluations, in the assessments?
The only cost was actually paper. We made copies of this. We made copies of the Spices, and we were allowed to because it was technically for educational purposes. So really the only cost, so the cost was the paper. So it was a minimal expense there. The other cost was payroll, because this was a mandated education event, and so it did add, but we typically took care. The nurses signed up to attend during their normal workday, and so it really should have had minimal impact on overtime. So that was kind of the agreement. If the nurses would cover each other so that they could get to the training, so there was minimal payroll burden there too. So really, I think the payout for this was minimal. Yeah, most of it was my legwork that kept it all going.
So for the most part, it sounds like it was just one more piece of paper that the patients had to fill out, or the nurses had to ask about.
Right.
In an otherwise admission process. Okay.
Luckily, the time it took to actually incorporate it into the admission workflow was minimal at best. And the nurses filled it out for the patient, and that way they were able to script the questions a little bit better to get a more accurate response, and to avoid the just check the box really quick so you get done filling out the form. The nurses, we had done a little bit of role playing along the way and talked about how to ask the questions so that get an appropriate response. So the nurse actually did that actual filling out the form.
This is Dennis here. Were there any other tools that you looked at to make this assessment?
This is the primary one that I looked at. You know, I looked at lots of things, and like there's a CATS index for, you know, functional ability, but none of them were comprehensive enough for me. They were comprehensive, but they were also very long, and so they would have added a lot of work for somebody. And so this is the one. When I saw this one, I thought, okay, I think I can make this work based on the setting and based on some of the things I was seeing already. So it just, I think I was a little bit lucky, and then I found something that really caught a lot of things that were prevalent already that we were missing. So I was a little bit lucky that it really did fit nicely.
Thank you.
This is Vera. I'll tell you what I like. In one of your implications at the end of the paper, you suggested that the educational program continue for new employees in this organization.
Yes.
I think that's a great way to get nurses on board before they, I guess, become accustomed to a routine. Is that you hit them as soon as they come into the organization, and it becomes, you know, a normal practice.
That was my idea. I thought, you know, if we had all the existing nurses already trained, and then as new ones came on board, they could go through this similar training. And at the time, I was willing to do the training because really I had developed the training session. So I was willing to take that on. And so there's a lot of moving parts with even that initial orientation. They would have bought into it. They would have. But it needed to be done, and it still needs to be done, regardless whether I'm there or not. I think these needs are hopefully being met because a lot of those nurses are still working. So I think it's ingrained in their head now. Some of these special issues that come up with these older folks, I think, so it's turned practice a little bit, at least for that facility right now.
Yeah, this is a problem that we're seeing really in nursing in general, where we have the tools that are reliable and valid, but it's taking sometimes decades for research to be translated into evidence-based practice. And I have no idea why it's taking that long, but we have the tools out there. The literature, the researches have been done, the evidence has been proven, and yet it cannot translate into our daily practice. Any thoughts about why you think that is?
I think it's time. I think it's time, available time during a practice day. And I think it's willingness to change that may be a big thing. Or I think people are willing to change. But it's actually having the time to evaluate for, identifying the problem. And I think regardless of the organization we work in, we can identify the problem easy enough. But who has the actual time to mobilize the next step? So I would, for this project, I made the time, and so that's it. I was dedicated to working on all this and reviewing evidence. But realistically, when finances drive the majority, if you're in advanced practice, finances are driving your day. I think that's providers, or we're losing. We just run out of time, or we run out of steam, because if we're seeing patients all day, regardless if we're advanced practice or not, we're seeing patients all day long. We're emotionally exhausted at the end of the day. And so I think it's time, and I think it's some organizations have cut out quality improvement people. I know one of the big ones here in Minnesota has cut out the nursing research or the research department and the quality improvement people to a great degree. And so some of those positions get cut because I think the assumption is those responsibilities can be absorbed elsewhere, when in fact I think the reality is they just don't, and things are repeatedly put on the to-do list, and then so nothing changes. That's just my opinion on it.
Thank you.
You're welcome.
Dennis, I have a question for you, if you're still here. Are you still on?
I am.
Oh,
Yeah. Dennis, did I hear you say that you work in the VA?
I used to.
Oh, okay. I would have thought that the VA would have had perhaps a tool, perhaps they would be using the SPICES, or maybe they would have another tool to assess the veterans.
Yeah, they have a pretty exhaustive inpatient tool that they use. It's part of the medical record. Being an outpatient, I wasn't that familiar with it. I do know that they do an audit C as part of the assessment. They do a gain integrity of falls assessment. You know, it sounds like the SPICES might be, could help minimize that on and on documentation. And again, as Keith had said, you have check the box. It's part of the electronic medical record, and you go through and you check the box to get it done. And I'm not sure how much of a true assessment that they have. I can say that the VA at the Asheville Center, our patient population is older than the average veterans service elsewhere.
Oh, interesting. Interesting.
Asheville is a
Have you seen
retirement center.
It's on the top 10 list in many places. Yeah, the SPICE assessment tool, I was really lucky because Dr. McRae sent it to me. It addresses sleep disorders, problems with eating or feeding, incontinence, confusion, evidence of falls, and skin breakdown. I think those are not necessarily, the incontinence might be something that a lot of people might miss because it's probably not something that is generally asked during an admission.
I think that's a
So
good
what are your future plans, Dr. McRae? We have the last 5 minutes. Are you planning on following up with this research in any way?
I would like to continue it on. I would like to pursue the sleep a little bit more because I think that's still an unmet need. I think the data supports it in these settings. To have an earlier intervention, and whether it be a sleep medication, not necessarily a benzodiazepine or some other addictive substance, but to have a better plan in place for when these folks are admitted or even on the outpatient basis, how are we managing sleep? Because the literature also suggests that if it's not managed and if they go back home from an inpatient setting, they're much likelier to go back to using the substance that helped them sleep to begin with. So I would hope to look at some of this closer and maybe put something together on paper and get it back in the journal and as a follow-up, and hopefully get some of that information out there. Other than that, I'm not really sure what else is in store for me. I work at my hospital practice, and I'm teaching in both an undergrad and a graduate program right now, so I'm getting the words out there on how to be a good nurse and how to be a good provider. And I don't know, it's been a really interesting experience with this journal and getting my work published. It's been really added many dimensions to something that I really didn't think it was attainable, and I'm really grateful that I've been given this opportunity.
Dr. McRae, this is Ann Mitchell. I'm the new editor for Addictions Nursing, and I saw that you were going to be at the Nurse Practitioner Conference in June.
Yes.
So I'll be there as well. So perhaps we can set up a time that we could meet.
Oh, that would be great. Yeah, I'm speaking on the same exact topic on Tuesday, the opening day of the conference. I'm doing a rapid fire presentation on this same thing. So I will be there majority of them. Yep.
Great. Yeah, I saw that.
So yeah, that would be great if we could set up a time to meet. I'll be there and I can absolutely make time available for you.
Yep. Sounds great.
Excellent. Thank you so much.
Are there any remaining questions for Dr. McRae or comments?
If I could just add in quick before we close, if anybody here on the panel that hears this has any more questions, my contact information is on the bottom of the article. And I'm more than willing to help you if your facility is interested in including some of these or looking to see what kind of content I included with my geriatric, kind of my nurse crash course in older adults. I'd be more than willing to talk to you more about it or help you guys get in that direction, because it can be a little bit daunting to have to put all that together or to try to figure out what to do next. So I'm more than willing to be a resource to any of you.
Thank you, Dr. McRae.
Very kind offer. And I just want to remind people that they can apply for the continuing education credits. As an Insta member, there is a discount, so just make sure you go through the JAN website. I think it's the JAN website or that's quite remembering now how I did it, but you will get a 30% discount on it. So I want to thank everybody for coming. I appreciated the interaction and the participation of so many of you. Karen, I hope we can get you fixed up so that you'll be able to speak for yourself next time. And maybe, well, you'll get an email or reminder for the next journal club, which will be a few weeks after the next journal comes out. Anne, do you have anything you want to add to that, or Chris?
I would just say to put on your schedules, I believe it's April 22nd. And
Great.
We'll make sure that the emails are going out to all the membership.
Yeah.
Is it going to be at the same time, 12 noon?
Yes.
Okay, great. Thank you.
Is that convenient, Vera?
That is convenient, yes. Thank you.
Okay. It's so hard now that we are fully international. It just is hard to choose one time that works for everybody, but I'm glad. Okay. Thank you very much.
Just one quick thing, Lynn, on page 247 of the print copy, there's information. There's a box there with information about continuing education and the process for getting credit. So
great. Thank you. Thanks for highlighting that for us.
Yeah, sure.
And thank you so much, Dr. McRae, for joining us. It really adds so much.
My pleasure.
Yeah, it was great.
Right.
It's excellent.
Thank you to everybody who had.
Thank you.
Thank you all.
Thank you.
Bye-bye.
Thank you. Bye-bye.